Puneet, can we start? So, good evening and good morning and good afternoon to a lot of people who have joined internationally to this webinar on multi-inflammatory syndrome in children and newborn. And I think it is very timely that we are doing this webinar, which is going to be evidence-based webinar. And I'm so happy that we have two international speakers who are going to share their experience from US. One of them is Venkat Shankar. He's Amsonian. He did his MD from AIIMS, New Delhi. He's professor of clinical anesthesia and critical care medicine in Perelman School of Medicine, University of Pennsylvania. He's medical director of cardiac intensive care unit at Children's Hospital of Philadelphia, USA. Thank you, Venkat, for joining for this webinar. And we have another internationally known speaker, excellent orator, Satyan Lakshman Rusimha from University of California. And I know him for very long. He is mentored by one of our teachers, Dharampuri Vidyasagar at University of Illinois, Chicago, who superannuated from there. He is, Satyan is professor and chair of pediatrics at University of California, Davis Children's Hospital, and he is pediatrician in chief and a neonatologist. So welcome, Satyan, to this webinar. And then we have our own colleague, my colleague Sushil Kabra, who is a pediatric pulmonologist. And along with him is Rakesh Lodha, who is professor of pediatrics. Both Sushil and Rakesh has been instrumental in making guidelines for COVID in children and multi-system inflammatory syndrome for Government of India. And then we have Dr. Praveen Kumar, who is head of neonatology at PGI Chandigarh, who is going to moderate the session for newborns. So may I request our director, sir, for giving, saying few words to all the attendees and all the facilitators for this webinar. Over to you, sir.
Thank you very much. And like you said, good evening, good morning, or good afternoon, depending where exactly you are. First of all, let me really congratulate the Department of Pediatrics led by Professor Ashok Rarity and his team, especially Dr. Kabra and Dr. Lodha, for really organizing this very timely webinar on COVID-19 multisystem inflammatory syndrome in children and newborn. Because as we are seeing this surge and there's this fear that more and more children will now start getting COVID-19, there is an urgent need for us to really be able to understand how best to manage children, and we should not really start looking at them as small adults, and what we are doing for adults cannot be translated to how we are going to manage children. And therefore, this is something which we really need to understand. It's been about a year. In April last year, the severe inflammation-related this syndrome, which happens with COVID-19, was reported. I remember at that point in time, people said that this is an incomplete or atypical Kawasaki syndrome, and it was thought to be a part of that. But we've come a long way since then. And we realize that this is a distinct entity, which is basically a hyperinflammatory syndrome occurring about 2 to 6 weeks after COVID-19. And now various association groups across the world have actually come out with diagnostic criteria. There is going to be a fear that in the coming few months, we may see a surge in the number of children who get affected as far as India is concerned. And therefore, there is a need not only for pediatricians in tertiary care hospitals, but even in other areas to really gear themselves up in managing not only COVID-19, but also the multi-system inflammatory syndrome, which we may see. And we all know that we really don't have a diagnostic test which would say that, yes, this is MIS. And that's why it's very important for us to develop two things. One is what should be the index of suspicion? When should you suspect it? And therefore, if you suspect it, what should you do? Should you look at fever? Should you look at inflammatory markers? Should you look at multi-system organ involvement? Should you look at serological tests or do an RT-PCR? And what are the tests or what are the sort of diseases that you should rule out before you say that this is MIS? So I think these are a lot of things that we need to work on. And of course, then the whole issue becomes, what is the ideal treatment? We know that this is something which occurs post-COVID, and therefore there is really no need to give antiviral like remdesivir and other things. But there's the whole issue of steroids, IVIG, when to give, when not to give in resource-limited countries like India. What is the role of IVIG and whether we should give that upfront or we should have certain criteria for that. I think there are a lot of things that need to be discussed. Therefore, again, let me really congratulate the entire team and really express my gratitude to Dr. Satyam, Dr. Venkat for coming on board and really discussing this syndrome with the Indian faculty and Indian pediatricians, because we will gain a lot from your own experience as far as the syndrome is concerned. But I would just say that once we do that, we need to look at the Indian perspective and see how we can make guidelines which are India specific and useful in our country, keeping the scenario in mind as far as India is concerned. So thank you very much, and I wish you all the best. And once again, thank you for inviting me and asking me to say a few words. Thank you.
So you need to unmute, sir, Dr. Rarity, sir.
Thank you, sir, for joining for this webinar. We all know, sir, it is all due to you. The entire country is fighting for this pandemic. And as you rightly said, we have to be worried about children because this wave is behaving differently. And we have to keep our eyes open for making a diagnosis of multi-system inflammatory syndrome in newborn babies and children. Thank you, sir, for your kind words. And as you must have seen that this webinar, we are going to cover the US perspective and then the Indian perspective, and then we are going to come out with some guidelines what to do for children who are having MIS, so that we do no harm to the kids, we don't overtreat, and we don't over-investigate the children and do the needful, what is rational for management of the children. Thank you, sir. So with these words, may I ask Rakesh Lodha to steer the next session for Venkat. Over to you, Rakesh.
Yeah, thank you, sir. Good evening, everybody. So we'll just have the first session on MISC in children. And as has been nicely been summarized by Dr. Guleria, it was a condition first reported in children from UK, a small series in April 2020. And thereafter, we have had multiple series that have been reported. And it seems to be a condition which seems to be similar to Kawasaki disease, but it has its own differences. The attempts to look at the epidemiology, it seems to be a rare condition, and of all children who have COVID, confirmed COVID, less than 1% are likely to have MISC. So as a condition in itself, it seems to be rare. But as the absolute number of children who are infected increases, we are going to see more cases. Now, there's some data which comes from the New York State where they looked at individuals less than 21 years old, and they tried to look at what the overall incidence is. So the confirmed COVID-19 cases, the incidence was about 320 cases per 100,000. And the number of, for MISC, the incidence was about 2 per 100,000. So it again comes to overall less than 1%. Now, we have some very preliminary data from which I could get from colleagues at the ICMR. They're running a registry. While most of the individuals who are enrolled in that registry are adults, but of 400 odd children who were hospitalized for COVID-19, about 10%, that's about 40, possibly had MISC. So overall, the numbers may be less. Most of the children have mild or asymptomatic infections, and only a few need to be hospitalized, and very few need to get into intensive care. But as the wave progresses, more children who have been infected, we are likely to see, more cases of MISC. Now, having said that, the current definitions were primarily what, for let's say for WHO, these were like surveillance definition, with the idea that once we collect data, we may be able to tease out and define a very specific phenotype based on certain criteria. One of the key things that has to be looked at when we are saying that we consider diagnosis of MISC is ruling out the common conditions, and which in countries like India would have a strong overlap with what the features of MISC would be. So conditions like bacterial infections, dengue, toxic shock syndrome, other infections are likely to overlap. And one of the key things, the challenge is to be looking at how one could differentiate, because at times the diagnostic test for many of the conditions which have to be ruled out may not be there. So what would really be when we should be having high index of suspicion is something which is critical. The other challenge is, as the pandemic progresses, the number of kids who would show up evidence of exposure to the virus in terms of serology being positive, that's going to increase. So just antibody positive with some of the other features possibly may not qualify, but we need to be able to tease out, because the management of this syndrome would be different from, let's say, any other condition that we may be considering. So there are definitely challenges which we would face in a situation like we have other infections and all. So with this background, we have really an interesting lineup here. We are going to hear from Dr. Shankar about what's the perspective from the United States. And then Dr. Kabra is going to follow it up with, what the Indian perspective is and what the challenges would be. And the session would be open for questions, and the questions could actually be written down on the YouTube chat box. We'll try and collate, and we'll have our experts to address that. So with this, I would hand over to Dr. Shankar.
Thanks, Rakesh, and thank you, Dr. Rarity, Dr. Guleria, Dr. Kabra, and Dr. Lodha for inviting me to this panel. It's indeed an honor and a privilege to be able to share some of our experience, as well as talk in general, as Dr. Lodha has already said, a syndrome which we fully do not understand yet, and which is still evolving, and something that we would have a better sense in the days and months and years to come. So, as mentioned by Dr. Lodha and Dr. Guleria, that the last year, in April of 2020, there were reports from both UK and Italy of children coming down with what appeared initially like a temporal relationship with just following a COVID peak in adults. And the syndrome mimicked quite a bit what we at that point thought was looking like Kawasaki's disease. Over the last year or so, we have learned quite a bit, and we'll have expanded definition of the syndrome, as well as the spectrum of the illness has evolved. And the phenotype, or the various kinds of manifestations, have become a little more clearer, although a lot of clarity still is not there. So there is the old story, which is prevalent in various religion and cultures, Buddhism, Hinduism, Panchatantra, about the elephant and the six blind men. And we are in a very similar situation right now. Depending on who you talk to, you may get a perspective that is true, but may not be the entire depiction of what's the full picture. And here, as shown in this cartoon, the epidemiologist, including in the United States, the CDC, has a very different perspective. They have published few case reports and have classified into few phenotypes, which I believe Dr. Kabra is going to talk later. The rheumatologists have come with a guidance document from the American College of Rheumatology. The ICU physicians have been collaborating and in informal networks and formal networks, and have initially had feared that we will have a huge onslaught of these patients in our ICU, flooding our ICUs, just like the adult COVID pandemic. But fortunately for us, it hasn't happened that bad. And in fact, initially we were putting all these patients in the ICU, and increasingly we have become a little more comfortable managing some of them outside the ICU. And in fact, there is some move to even say that some of these patients can be managed on an outpatient basis. Just to give a sense, I work in a 550-bed children's hospital, which all 550 beds are for children. We have a 75-bed pediatric ICU and a 35-bed cardiac ICU and a 100-bed neonatal ICU. And we only have a 10-bed COVID-related patient unit, which is separate. And we manage our MIS-C in that area. And of late, we have been having only around 3 patients or so at any given time. So, whereas our adult counterparts have continued to have quite a bit of COVID illness. If I can go back to the previous slide, sorry, Dr. Rarity, and the cardiologists have a different viewpoint. They think that most of the morbidity is secondary to MIS-C, is secondary to heart disease, and that's true. And they have coming up with something which is parallel to that of Kawasaki's management philosophy. And same is true for hematologists who have their recommendations about both the acute phase, where there could be problems with the DIC-like picture, and subsequently hypercoagulable state. And the infectious disease obviously is very interested, and they have their own perspective. If I could have the next slide. As Dr. Loda said, the case definitions which have been promoted currently, at least 3 major case definitions exist. The first one came from the Royal College of Pediatrics from UK, and then soon thereafter from World Health Organization, WHO, and then CDC in last May of 2020. All these definitions have some minor differences between them. But I think the broad principle is that these are all very broad definitions, and they on purpose, they are very inclusive. And that is because we are at the very early stages of a novel syndrome, which we fully don't understand. And the goal of these organizations is to collect as much data and information so that we can have further understanding of this disease from an epidemiological standpoint and a clinical standpoint. So the important thing in both US context as well as in Indian context, to interpret with caution the broad definition for a particular child, and whether that I think we all have temptation to label, to find a label for any syndrome or anything we see. It's easy. We are much more comfortable giving a label to a syndrome, and then the problem is some of this may lead to an overdiagnosis and or overtreatment. So I think one has to be cautious, especially in the context when there is a raging pandemic and the exposure and some of the linkage to the SARS-CoV-2 might be almost ubiquitous, that virtually any child coming to you may have had an exposure. If I could have the next slide, please. So the World Health Organization case definition has 6 criteria, and all of those have to be met because it's a pediatric disease syndrome. So it's less than 19 years of age, or less than 20 years of age. A fever, which defined as the degree of fever, but has to be more than or equal to 3 days. And then presence of at least 2 of the multi-system involvement, which includes the skin, the mucocutaneous inflammation of the non-purulent conjunctivitis, just something very similar to the Kawasaki syndrome. Presence of hypotension or shock, presence of cardiac dysfunction, which could involve either clinical evidence and or echocardiac evidence of cardiac inflammation or cardiac dysfunction, presence of coagulation disorder, either clinical and or lab parameters of DIC or elevated D dimers, and presence of gastrointestinal symptoms. Of interest that last year, initial cases, majority of the patients presented, and including the United States, presented initially with a large component of their initial presentation included very prominent GI symptoms of abdominal pain, diarrhea, vomiting, and then shock state. So I think it for many of us initially, it mimicked something which we see often with toxic shock syndrome. The fourth criteria is that there have to be elevated markers of inflammation, and we can go into more details as the webinar progresses. This includes this sedimentation rate or C-reactive protein or procalcitonin and any other acute phase reactants. One of the most important criteria of all the six is one has to make sure that no other obvious and much more common disease, which could be either infection or like bacterial sepsis or anything like streptococcal or staphylococcal toxic shock syndrome, or for that matter, any connective tissue disorder or any other causes that are much more common than MIS-C, have to be ruled out or have to be at least considered and made sure that they are not present. And then the last is an evidence of a linkage to SARS-CoV-2 infection, either by a currently positive RT-PCR or a positive antigen test, or a past exposure by presence of antibodies or serology, and then or just a epidemiological contact with an individual with COVID-19 in the last 4 to 6 weeks. The CDC definition has 4 criteria, and all of them have to be met. There's the age criteria of less than 21 years. Then the clinical criteria. Then the third is the most important criteria, that there should not be an alternative plausible diagnosis. And we'll come back to the clinical criteria in a second. And then the fourth criteria of recent exposure or presence of SARS-CoV-2 infection. And that's the similar RT-PCR antigen test, serology, or COVID exposure within past 4 weeks before the onset of symptoms. Unfortunately, whenever the background incidence of COVID is going to increase, the last bullet point and the fourth criteria is going to be pretty much universally present for many children in Indian context right now. So one has to be extremely careful in using that as a sole reason, or for that matter, as Dr. Lodha said, even positive serology as a criteria to diagnose this disease. In terms of the clinical manifestation, fever, and CDC definitely defines a certain degree of fever of more than 38 degrees or 100.4 degree Fahrenheit for at least 24 hours, or a subjective fever for more than 24 hours in case the fever was not measured. Presence of lab parameters of acute phase reactants, which could be C-reactive protein, sedimentation rate, fibrinogen, procalcitonin, D dimers, or elevated ferritin, LDH, presence of increased neutrophils and or lymphocytopenia, and drop in the serum albumin level. And then clinical presence of multi-system involvement, at least 2 of the systems between cardiovascular, respiratory, renal, neurological, hematological, and GI and dermatological. And then the severe disease has to be present. And this, of course, is coming under some revision now because of an increased recognition that there is a spectrum of phenotype where one could have very similar manifestation, but the patient may not require hospitalization. Could I have the next slide, please? So if one could summarize all the case definitions, then there are basically 6 major core diagnostic criteria. Age, that is to be less than 20 years of age. Persistent fever, which has to be universally present. Signs of hyperinflammation, and that's mostly as diagnosed by presence of increased acute inflammatory markers, whatever we decide to choose to use in a particular context. Presence of multi-system involvement, organ system involvement, which at least 2 or more organs should be involved. And as I mentioned, some of the common ones that initially presented were GI and cardiovascular and mucocutaneous organs. Also, we saw in the last year, many of these patients had significant CNS involvement in terms of irritability, general non-focal neurological findings, which was again something very similar to what we have seen in patients with Kawasaki's disease. We haven't done a whole lot of spinal taps in these patients to rule out any acute inflammation of the meningeal space. And then the fifth is linkage to SARS-CoV-2. And the most important criteria is one should definitely exclude any other possible and common diagnosis, especially in the context, say, in India, where there could be other infectious causes, which could be producing all these non-specific first 4 or 5 symptom categories, criteria that we talked about. We could have next slide, please. This is one suggested approach, and I know that Dr. Cabra later on is going to talk about a tiered approach, which has been recommended by the American College of Rheumatology. Essentially, if you have fever for more than 3 days, or a child with any degree of fever or any duration of fever presenting in shock, one should immediately rule out other causes of common causes of fever and infection that you would typically do. If there is a shock, you will obviously, while you're investigating the causes, you will treat the shock. You look for the dysfunction of the major organ systems that we talked about in terms of cardiac, GI, skin, and central nervous system. We'll talk a little more in detail about the cardiac evaluation, but most of this would depend on both clinical as well as lab parameters. You look for inflammatory markers and markers for end organ function, and you also look for any linkage with SARS-CoV-2. The SARS-CoV-2 linkage can be found by just looking for either RT-PCR or antigen or serology. In terms of markers for inflammation, CBC, C-reactive protein, and sedimentation rate has been often suggested as the initial go-to panel, which is easily available rather than spending a whole lot of effort, money, and amount of blood to get the other markers. And if the C-reactive protein and sedimentation rates are not elevated, it's highly unlikely that these patients would be fitting into a category of hyperinflammation. The cardiac evaluation would include, among other things, a B natriuretic peptide, B-type, or anti-pro-BNP, a troponin level, as well as getting an EKG and echocardiogram. We'll talk a little more in detail in the next slide about the, if I can go back to the previous slide, sorry, to the cardiac functions. And in terms of hematology, fibrinogen, D-dimers, and LDH can be looked, and the end organ functions of liver and kidneys can be evaluated. Next slide, please. For cardiac evaluations, they're basically in 3 buckets. The initial evaluation would include looking at the biomarkers for cardiac function, the electrocardiogram, and the echocardiogram. The biomarkers which are being found to be consistently abnormal include the BNP or NT-proBNP, the troponin level. The EKG, again, does not necessarily always show an abnormal finding, but there is an increasing recognition that there is presence of both non-specific ST changes, but increasingly around a fifth of the patients who are sick enough to get into the ICU seem to have at least some evidence of a first-degree AV conduction delay. and some of them progressing into a second and higher degree of AV block and in conduction blocks. The echocardiogram is the most helpful evaluation tool, and majority of the patients who have cardiac dysfunction will show some evidence of LV dysfunction, and in terms of decreased LV ejection fraction. There is around a 20% incidence in the initial series of the hospitalized patients in US of coronary dilation, as well as a tiny amount of them having coronary artery aneurysm, something very similar to that seen in Kawasaki's disease. Some, but not a whole lot of patients have pericardial effusions, but it's not been a major presenting picture. The follow-up of these labs or these echocardiograms will depend on the clinical picture. We sometimes do the echocardiogram every 24 to 48 hours to decide upon therapies and response to therapies, but often you may need to repeat at least once more within 4 to 7 days after the initial presentation. There has been a recommendation, again, it's highly controversial, whether some of these patients who have initially presented with significant LV dysfunction should have a follow-up MRI of the heart to look for the cardiac scarring and long-term consequences like a cardiac dysfunction. We have the next slide, please. So overall, for a sick patient with MISC who is admitted to the hospital and or to the ICU, the management principles involves around 4 major focus areas. It's the management of the shock, which is present in almost around half of these patients, supporting the end organs, and starting on immunomodulator or anti-inflammatory therapy, and then thromboprophylaxis for preventing any thromboembolic complications. We could have the next slide. The shock management, again, is a pretty standard shock management. Majority of the patients with MISC shock are in a state of cardiogenic shock secondary to cardiac dysfunction. So one has to be extremely careful with the amount of fluid resuscitation and to be administered to prevent any significant pulmonary edema and or any congestion. We typically use a combination of either inotrope like milrinone along with if the patient needs blood pressure control, blood pressure support, either a vasoconstrictor or vasopressor like dopamine or norepinephrine, in occasional cases epinephrine. The good news is that majority of these patients, although may rapidly have an LV dysfunction show up, they seem to respond pretty significantly with the therapies that we're going to talk about in the 48 to 72 hour period, with majority in the initial experience not requiring more than 4 to 7 days of ICU stay. The end organ support is again standard ICU in terms of giving blood products for correct any coagulation abnormalities, supporting any respiratory tract failure, either with a non-invasive support like CPAP, high flow nasal cannula, and or invasive mechanical ventilation, and the renal support in terms of electrolyte management and in a rare instance, renal replacement therapy. The good news is majority of these patients are also not requiring, as we have gotten more comfortable with managing any kind of major respiratory support, and a lot of these off late we have been managing using non-invasive support of CPAP or high flow nasal cannula. The crux of the management involves stopping the hyperinflammation, and currently majority in the United States, majority of the patients are getting intravenous immunoglobulin at 2 grams per kilogram dose. We'll talk about that in the next slide, and or glucocorticoids, and some are getting both. And then there is a second tier of IL-1 antagonists like anakinra. And then the thromboprophylaxis involves aspirin and or enoxaparin. Could I have the next slide? The most important thing to remember is at this time, we do not have a large degree of evidence to recommend a particular treatment strategy, which may be frustrating, but it is the truth. We do not have sufficient data and or systematically collected follow-up to say that one or the other immunomodulating regimen that we are using is beneficial or harmful. Most of the current treatment has been modeled after either a treatment for Kawasaki disease or Kawasaki shock syndrome and or toxic shock syndrome. As the knowledge of what the syndrome is and how best to treat, and are there various different distinctive phenotypes and each of them require a different approach, will become more clear as we learn more about the disease. I believe Dr. Lodha is one of the coordinators in India about the study that has been sponsored by World Health Organization about what's called BAT study or Best Available Treatment Study, which, considering that there is not enough time or the volume and the varied places that all this is being managed, to do something like a randomized controlled trial, this is a study that is comparing simultaneous use of multiple regimen that is being used by the clinicians at various locations. And the preliminary data is being published very soon to compare either IVIG versus steroids versus a combination therapy. Could I have the next slide? Currently, at least based on an expert panel recommendation, and these are only around 15 experts, 11 of them rheumatologists, a couple of intensivists and cardiologists, and an ID physicians in the United States, under the rubric of American College of Rheumatology, a task force was constituted, and they have made an expert panel recommendation. Again, with fully understanding that this is going to change and evolve as we gather more evidence. But the current guidance from American College of Rheumatology, as I mentioned, non-evidence-based, but an expert recommendation is to use as the first line intravenous immunoglobulin of 2 grams per kilogram. There is no role for repeating IVIG if there is no response. Some institutions are not using IVIG as the initial regimen and are rather choosing to use steroids in the milder cases or the cases where there is not as much presence of a Kawasaki-like initial presentation. And as I said, we would have a better sense in a few months. There is also an increasing push in some centers to use a combination of IVIG along with methylprednisolone of 1 to 2 milligrams per kilogram per dose per day in divided doses, because there is some early evidence in case series that this may result in an earlier resolution of the cardiac dysfunction and a shorter ICU stay. For somebody who has a refractory is defined as either persistent fever or persistent cardiac dysfunction beyond 72 hours after the initial treatment, there's been a recommendation to use a high dose of pulse steroids of methylprednisolone of 10 to 30 milligrams per kilogram, or use a high dose anakinra, which can be sparing the side effects of steroids. Again, these are very preliminary and not a large number of experience in any of our large centers. Could I have the next slide, please? And then the last is the thromboprophylaxis. There is no current evidence-based, strong evidence-based recommendation. We do not know which regimens are beneficial or harmful, and one has to pick based on individual risk and benefit. That being said, if I could have the next slide, the current consensus is to start antiplatelet therapy. This again is modeling after the Kawasaki disease, with the understanding that a large number of patients do have some evidence of coronary dilation. to start aspirin in 3 to 5 milligrams per kilogram per day with a maximum of 81 milligrams, which is what's called a baby aspirin in US for all children, and leave it on for at least 4 weeks. And in a follow-up echo, if there is no coronary dilation, then to stop it. So anticoagulation therapy, in addition to the aspirin, has been recommended, like enoxaparin, if the ejection fraction and the echo is less than 35%, or if there is presence of a large coronary giant aneurysms, which is defined as more than a Z-score of more than 10. Could I have the next slide? The last 2 slides, I wanted to emphasize some facts, and some of these are derived from the same guidance document from the American College of Rheumatology, that the vast majority of children with COVID present with very mild symptoms have excellent outcomes. MIS-C is indeed a very rare complication of SARS-CoV-2, and as I mentioned, we were expecting a larger number, but we haven't seen, which we are glad and fortunate, and feel that we are lucky. A child under investigation for MIS-C should be evaluated for all the other possible and much more common infectious and non-infectious causes which cause fever and increased acute phase reactants, which includes infections, malignancies, rheumatological diseases, connective tissue disorders. An outpatient evaluation of MIS-C is possible, and it's appropriate for a child who is otherwise well appearing and with stable vital signs, provided you can continue to follow them up. And this is important in a current situation when the pressure may be quite significant, and you may want to touch which kind of patients get admitted. The diagnostics, the next slide, the diagnostic evaluation of this should be completed before we start immunomodulating therapy. Of course, the exceptions being a child who is in a shock state where there is not enough time where you can do the evaluation as well as treatment simultaneously. And last, but and the other thing that is very we are fortunate as pediatricians is that MIS-C has excellent outcomes, and unlike COVID-19, the reported mortality is less than 2%. And in fact, as we are recognizing a milder spectrum of the disease, it's probably going to be even less than 2%. And as Dr. Devrari mentioned early on, I think one of the key take home from this and the further discussion that's going to follow is to avoid the temptation for overdiagnosis just based on the case definition and overtreatment. And again, it is good to keep an open mind and understand that this may be a major problem, but on the other hand, understand that we fully do not have a full understanding of where things are and how best to treat these patients. Thank you.
Yeah, thank you, Dr. Shankar. I think that was very comprehensively covered various aspects of MIS-C in terms of the dilemmas and the diagnosis, as well as the management, and what the current approach would be for how one would go about diagnosing and managing these children. And also you highlighted caveats in terms of not really going ahead and overdiagnosing some of these conditions, importance of ruling out. And so this is, I think this sets the stage for the next session, which is going to be taken by Dr. Sushil Kabra, who's going to highlight some of the Indian studies, some of the aspects that we need to look at, and also discuss and brief the current guidelines that have been put together by a group of experts for the Ministry of Health in India. So now I request Dr. Kabra to start this session. Thank you.
Thank you, Dr. Rakesh. In next few minutes, I'll try to discuss about the multisystem inflammatory syndrome temporally related to SARS-CoV-2 in children, its Indian context, its clinical features, data, along with that, how to adopt the clinical guidelines which has been suggested for management in Indian scenario. Next slide. Dr. Shankar has already described the details regarding WHO criteria for making a diagnosis of multisystem inflammatory disorder, ASIST syndrome in children. So again, I re-emphasize, it includes age less than 20 years with a fever for more than 3 days, with two of the following, including either skin manifestations, hypotension or shock, features of myocardial dysfunction, pericarditis, evidence of coagulopathy, and acute gastrointestinal problems. And there should be elevated markers of inflammation. It may be just simple ESR, C-reactive protein, or procalcitonin. And no other obvious microbial cause of inflammation, including bacterial sepsis, staphylococcus, or streptococcal shock syndrome. And in addition, there should be evidence of COVID-19 infection as documented by RT-PCR, antigen test, or serology, or even if the child has come in contact with a documented COVID-19 infection. Next slide, please. There are multiple case reports and few case series reported from India, and most describe the clinical features, outcome, and what treatment that given. Some atypical presentation has been reported. One is the child having a uveitis, status epilepticus, encephalopathy, neuropathy, gastrointestinal bleed, and so on. Next slide, please. Seeing a series which include 20 to 30 children in each series from different background and different hospitals. And as you can see, a study published last month only 32 children with a GI symptoms, cardiac symptoms, and coronary aneurysm. And the treatment, you can see pulse methylprednisolone or IVIG. And in all the series, majority of the patients received pulse methylprednisolone and some in addition to IVIG. And mortality in this series, there was no mortality. But if you see the other series, which is Gupta et al., 20 patients and even younger patients, less than 5 years, with encephalopathy, acute encephalitis-like illness, Kawasaki disease, toxic shock syndrome, and comorbidity with systemic complications, treated majority with steroids and only 4 patients with IVIG, but mortality was very high. Similarly, the last in this slide, 21 patients, and again it is the GI symptoms, respiratory symptoms, macular rashes, along with non-purulent conjunctivitis and renal involvement. And again you can see majority received methylprednisolone, with some patients getting IVIG, and even some of them received tocilizumab, and mortality is 3 out of 21. Next slide. So at other two series in which 23 patients, first series 23 patients, and again gastrointestinal, respiratory, rashes, conjunctivitis, and coronary involvement in 26%. And again, all of them received pulse methylprednisolone, and mortality is 1. And in the other series, 19 all age group, including 1.1 to 16 years, multi-organ involvement in 79%, and mucocutaneous involvement in 74%. Steroids only in 3, IVIG in 5, and mortality is 0. And even tocilizumab and steroids in 1. Next slide. So all these Indian experience suggest that there are different reports based on what is the hospital, which type of hospital they are, how the data were collected. Most of them were retrospective. Obviously, the reporting will be biased, and the treatment is not uniform. And people are using more of a methylprednisolone because IVIG is not easily available, expensive. Mortality is variable, and again, it reflects the type of hospital which are getting these patients. Some of these may be getting very severe cases, and therefore there is a need to have a registry to collect all the data, to collect whether only these 3 or 4 organ dysfunction are there, or there are multiple dysfunction also. So there is a need for uniformity in the data collection as well as in the management. Then only we will be able to say whether we can use only methylprednisolone or combination or IVIG. So pathophysiology is incompletely understood because condition is there in children who had infection previously and also in those who have an active infection also. So possible mechanism may be immune dysregulation, antibody enhancement, or T cell mediated damage or enhancement of inflammation. Next. So this is just a diagrammatic representation that whenever there is a viral infection, if there is an early interferon response, there will be rapid viral clearance and less of inflammation, so disease is mild. While if there is a delayed interferon response, in that case, viral clearance is delayed and there is a more inflammation presenting with severe disease in adults as well as including MISC in children. Next slide. So if we see the clinical spectrum, on one side it is a classical Kawasaki disease or incomplete disease with or without shock. In between we have hyperinflammation with myocarditis with or without shock presenting with fulminant heart failure and subacute heart failure. And then the extreme right is hyperinflammation without myocarditis presenting with shock and multi-organ failure. Next slide. Okay, next. So in a review, I think this slide is not very clearly visible, but we can see that 1/3 of the patient, which is called class 1, may have hyperinflammation with MODS and GI and cardiovascular dysfunction. Mortality is very low in this group and most of them will have a serology positive. Again, it will be in form of a early viral clearance and less of a inflammation, less of a mortality. Class 2 is in which again 1/3 with a severe respiratory distress, myocarditis, and there is an infection as indicated by RT-PCR positive in as many as 84%, and this group has the highest mortality. And in the class 3, again 1/3, age 6 years, they may have a KD or atypical Kawasaki disease and mortality is 0. 63% have a serology positive and 30% both serology and RT-PCR. So this is the spectrum across the cases. Next slide. So how to go about it in India? So one is, if a patient is having unremitting fever of more than 38 degrees with epidemiological link to SARS-CoV-2 infection and clinical features suggestive of MISC, first thing is to check whether there are any alternative diagnosis and look for shock and ARDS. If shock on ARDS is there, then we'll do all the investigation, which I'll be discussing in the next slide, tier 1 as well as tier 2. But if they are not there, but it is suggestive of MISC, you do a tier 1 evaluation. If it is positive, then you go for a tier 2. And if first screen is negative, look for alternative diagnosis. Because in India, we have to rule out other infections, including tropical infections. Next slide, please. So what is included in tier 1, which can be carried out in the primary care physician, like CBC, complete metabolic profile, including liver function, renal function, blood gas and glucose, C-reactive protein with or without ESR, and SARS-CoV-2 serology and or PCR. If PCR is negative, then obviously you will go for a serology. Next slide. Positive screen is defined as if CRP is more than 5 milligram per deciliter or ESR is 40, either of one. And at least one of these, like absolute lymphocyte count is less than 1000, platelet less than 150,000, sodium of less than 135, neutrophilia, and hypoalbuminemia. So if any of these out of these 5, then you will say that this is positive. So positive screen means if ESR is high, CRP is high, and any of these. So next slide. So in tier 2, we have to do a detailed cardiac evaluation, including ECG, echocardiography, BNP, TROP-T, inflammatory markers like procalcitonin, and PT, PTT, D-dimer, and fibrinogen, and LDH. Not necessarily all has to be done. Whatever is available can be carried out. Triglycerides, cytokine levels, if available, and blood smear examination. Next. So what should be the treatment? If MISC with shock or life-threatening disease, ARDS or shock. In that case, steroids with IV IgG may be given. Methylprednisolone 1 to 2 milligram per kilo, IV IgG 2 gram per kilo over 24 to 48 hours with antimicrobials simultaneously evaluate for tropical infection because it will not give us more time. Next slide. So if it is not life-threatening, rule out tropical infection first, give steroids methylprednisolone as a first line, or alternative is IV IgG as a first line as per availability, but we would suggest that in this group, we can continue to give methylprednisolone. Next. What about aspirin and enoxaparin? Dr. Shankar has already clarified it. For aspirin, indication would be thrombocytosis or coronary aneurysm of Z-score more than 2.5 and doses are 3 to 5 milligram per kilo per day. And maximum is 81 milligram per day. Enoxaparin indications would be coronary aneurysm, a Z-score of more than 10, thrombosis or ejection fraction of left ventricle is less than 35, and your target is to keep the factor 10A level between 0.5 to 1. Next. If it is not responding, then you can repeat IV IgG or give high dose IV steroids. That would be preferable with methylprednisolone 10 to 30 milligram per kilo as a bolus for 3 to 5 days. Next. So how to monitor? ECG every 48 hours. Echo you repeat at 7 to 14 days and 4 to 6 weeks. Repeat at 1 year if initial echo is abnormal. And optional is cardiac MRI and cardiac CT scan, as it was clearly described by Dr. Shankar. Next. Next slide. Yes. Next slide, please. Now I hand over to Dr. Praveen Kumar to moderate this next session. Dr. Praveen.
Thank you, Dr. Kabra.
So we will take all the questions at the end combined.
Okay.
Over to you, Praveen.
Yeah, thank you. So good evening and good morning to everyone. So we have heard a lot about the MIS-C in children from international expert Dr. Venkat and then Indian national expert Dr. Kabra. Then obviously the neonatologists are also beginning to kind of make this diagnosis and worried about this. And to talk about this possibility, I think we have the best person available to us internationally. And Dr. Satyan, I think, is very well known to the Indian audience as well across the world. And we have all been fond of his unique graphics and animations, where he makes the most complex, concepts sound so simple. We were very familiar with his book on ventilation along with P.K. Rajiv, and now for since the COVID started, we have seen his excellent publications clarifying many things about COVID in children and newborns. And he also gave us the classification about perinatal as well as vertical transmission. So I would straight away hand over to Dr. Satyan to begin his talk, and then later on we will discuss the Indian context. Satyan, please.
Thank you, Dr. Praveen and Dr. Devrari, for this opportunity. I really appreciate everything that's happening in India with the high prevalence of COVID. And as Dr. Venkat had suggested, in California and in New York, similar surges happened last year. But what you're going through is unprecedented. And I wish all your family speedy recovery and to stay safe. Let me talk briefly about MIS-C in newborn. This is a relatively new topic, and there is not much of literature on it. So a lot of what I'm going to say is speculative, and I want you to remember that. Before I start, I want to remind everybody that use of COVID-19 vaccines and IVIG in newborn period is experimental, and the federal FDA in America has not approved it as of yet. I will start off with a case to illustrate some of the difficulties in this diagnosis. This was something that happened around November last year in 2020, when the prevalence of COVID was very high in California. A 37-week gestation baby girl was born after 72 hours of rupture of membranes and presented with fever of 37.7 degrees centigrade and tachypnea. Mother had COVID-19 with mild symptoms 4 weeks prior to delivery, and the baby had a low white count, a lot of neutrophils, a lot of bands with low platelet count, and a very high C-reactive protein. The CKMB and troponin T were high as well. The initial suspicion was groupish streptococcal sepsis, and hence the baby was started on ampicillin and gentamicin, but this infant rapidly deteriorated to have shock and hypoxic failure and was switched to vancomycin and meropenem. At 48 hours, 2 blood cultures were negative, and this led to a suspicion that this may not be a bacterial sepsis. And further investigation was done, which showed on echocardiogram, showed low ejection fraction, tricuspid regurgitation with evidence of pulmonary hypertension. This baby was started on dopamine, norepinephrine, and inhaled nitric oxide. And because COVID was so prevalent in California at that time, a SARS-CoV-2 RT-PCR was sent off. And the RT-PCR was negative, but the IgG was positive and the IgM was negative. And at this time, there was a high suspicion this was probably a MIS-C in a newborn baby, and the baby got started on steroids. So this baby went on methylprednisolone, and in spite of starting on steroids, although there was a transient improvement, the baby deteriorated pretty fast. In the meantime, because of fever, a herpes simplex virus test was sent, and the type 2 blood PCR came back positive, and the baby needed to be started on acyclovir, but continued to deteriorate, went on ECMO, and eventually died. The reason I bring this case at the beginning of this talk is to illustrate the fact that when the prevalence of COVID is very high, as it is in India right now, many, many babies will test positive for IgG SARS-CoV-2. And in spite of that, thinking of other unusual and probably more common causes is really important in a baby that's deteriorating, and a orthodox treatment with a steroid therapy would not be recommended in these situations. So moving ahead, there are lots of differences between MIS-C, as was very well outlined by Dr. Venkat and Dr. Chabra and Dr. Lodha, and what happens in neonates. For example, if you consider these to be pregnant mothers, and the ones that are yellow in color or those that are negative for COVID, and the ones that are red or positive for COVID, when the prevalence of COVID increases, many of these pregnant mothers will have either previous history or current history of COVID. There was a time in New York City when approximately 25% of all mothers who were being tested before they came in for delivery were testing positive. And the situation in India right now is probably very similar. When you have such high positivity rate, it's quite likely that many of these mothers transmit their IgG anti-SARS-CoV antibodies to their neonates. So once these mothers deliver, those that are negative, most of their infants will be negative. But some of the infants born to these positive mothers can go on to have what is called as early onset neonatal COVID-19. And a large registry in the US involving over 8,000 mother-infant dyads has shown that early positivity in babies before discharge from the newborn nursery or from the NICU is fairly low, around 2%. In some of these infants, the babies look okay on the day of birth, but eventually might go on to develop a very rare condition called as MIS-N, which is multi-inflammatory syndrome in neonates, multisystem inflammatory syndrome in neonates. This is a very rare phenomenon with literally, to my knowledge, around 8 cases that are published, but there is increased awareness and more people are starting to recognize this condition. And that's really important to recognize this entity if it exists. The other possibility is that a baby, when the baby is born, does not have any infection, but over the next couple of 2 or 3 weeks, because the baby is surrounded by many family members, including the mother, who might be positive, these babies might acquire what is called as late onset neonatal COVID-19. Both these early onset and late onset eventually can theoretically lead to MIS-C in the neonatal period. And again, as mentioned earlier, this is a fairly rare condition and we don't know a lot about this. So the take-home message here is common conditions such as sepsis, asphyxia are a lot more common, even though you have a IgG positive for SARS-CoV-2, given the high prevalence of this disease in the country right now. It's important to think of other conditions, both viral and bacterial sepsis, and also asphyxia. So there were some questions in the chat about immunology, and I'll briefly go over this. So SARS-CoV-2, as many of you know, goes through 3 phases. The first stage is when you develop the infection, when the virus enters the nasopharyngeal area, causes colonization or mild infection. And in many people, especially in children, this is all they get. They continue to be mildly infected or completely asymptomatic, but very capable of transmitting the infection to other senior members in the family, especially grandparents. Subsequently, this goes on to create the stage 2, which is the pulmonary phase, where you start developing cough and other respiratory symptoms. And initially, it was thought that there is no pulmonary phase in children, and the pulmonary phase was very uncommon. But as Dr. Rarity was mentioning earlier, it's being recognized that with the new mutants in India, even children are experiencing more and more of a pulmonary infection from COVID-19. The third phase, which is probably the most alarming, is stage 3. And I have heard of many of my friends and colleagues here who developed COVID, but were relatively doing well for 5 to 7 days. But then after that, started having hypoxia and other problems. And this is due to a rapid activation of the immune system leading to a cytokine release or storm. And this hyperimmune response can lead to further deterioration in these patients, and hence the need for steroids in COVID-19, especially in adults. In a small subset of these patients, especially those with genetic predisposition, we really do not know what exactly causes this. We see an increased prevalence of what is called as multisystem inflammatory syndrome in children, or MIS-C, which manifests with various conditions that we talked about that were outlined in the previous 2 talks. So this MIS-C appears to be like a stage 4 or a different hyperimmune response, which has some kind of a genetic predisposition that we do not know yet, and various autoantigens are released which cause various inflammations in different syndromes. So we already heard about the features of COVID-19 and the criteria. Here is the illustration that goes over the CDC criteria. One thing that does not apply to neonates that's seen in children is the presence of fever. Fever has not been described in all neonates that have been reported. Some of them do have temperature instability and some do have high elevation of temperature, but this has not been a universal feature in the neonatal presentation so far. So here is the study that was mentioned in both the previous talks, Gottfried Cato et al. That came out of the reports of multisystem inflammatory syndrome in children in the US. And basically, approximately 25% of these children that presented with MIS-C had preceding COVID-19-like illness more than 7 days ago. And the median duration between illness and COVID-19 illness and the presentation of MIS-C was 27 days. So this is something that happens 4 weeks after the surge of COVID-19 among adults. The median age is 9 years, but the range was 2 weeks to 20 years. So there are some babies, neonates, who are part of this problem as well. The interesting phenomenon seen in the US is that this condition is more prevalent among Hispanic children and also African American or Black children compared to white children. And the etiology of this racial or ethnic profile is not really clear. Children who are obese or having pre-existing conditions are at a higher risk. And here are the various manifestations, treatments. And approximately 58% of these children required an ICU admission with an approximate length of stay of 5 days in the ICU. And as Dr. Venkat mentioned earlier, the incidence of death is fairly low. It's 1.4% in this syndrome, considerably lower than severe COVID requiring ICU admission seen in adults. So these are the features of MIS-C in children. What about neonates? Neonates are slightly different because in MIS-C, the patient who is getting the SARS-CoV-2 infection and the one having MIS-C is the same subject. In other words, if 9-year-old child gets SARS-CoV-2 infection or is exposed to SARS-CoV-2, 4 weeks later, the same child develops MIS-C. The unique feature of MIS-N in neonates is that the person getting the infection or is getting exposed to infection is the mother, whereas the subject who is developing MIS-N is the baby. So this is a mother to baby transmission of antibodies causing this illness. So what we think is the pathophysiology is that mother develops a mild or a asymptomatic or even a symptomatic COVID-19 infection. And there is transplacental transfer of antibodies. There's a maternal autoimmune response that leads to a neonatal inflammatory response in the child. The features that have been described in the 8 case reports, and I've also heard from various colleagues in India about more and more cases being described, are as follows. There is one report from the Middle East talking about pulmonary hypertension, a presentation of a baby with pulmonary hypertension. There have been several reports with myocarditis, with high troponin levels, high BNP, coronary aneurysms or coronary dilation, hypotension or shock, hypoperfusion, tachycardia, etc. There are increasing reports, as Dr. Venkat mentioned, about AV block, and I will talk about that in a second because there appear to be some antibodies produced by the mother that seem to have a unique affinity for the cardiac conduction tissue, and that might be the reason why we get an AV block. So it's really important to get an ECG in neonates when you suspect MIS-C. That's something that we commonly don't do in neonatology, and that's something you should think about. Temperature instability, either hypothermia or hyperthermia, both have been described. There are some babies who are presented with neck-like syndromes, with GI involvement with diarrhea and blood in the stools. Renal involvement has been seen as well. And there was one report, I believe, from Bangalore, which talked about erythema of the dependent portions of the occiput and buttocks, which resolved, which looked almost like a necrotic rash initially, and then it resolved later. The increase in inflammation and other markers, as pointed out by of the previous speakers, can also be seen in neonates. And some cases do respond to IVIG and steroid therapy, but this therapy should be given only for babies that require ICU care and that meet certain requirements. If you think of the immunology of MIS-N, this is where it is really interesting. And I saw some questions in the chat as to whether vaccines can lead to MIS-N. That's a question that has not been answered yet, but it's unlikely. And the reason is as follows. So when a mother develops an infection, there is a maternal innate immune response with the natural killer cells and dendritic cells being activated and leading to form neutrophils trying to fight the infection. Eventually, the T cells and B cells take over, resulting in plasma cells that are activated, which produce antibodies. So the maternal adaptive immune response involves 2 types of antibodies. The so-called good antibodies, shown in green here, these are the antiviral spike protein antibodies, typical to what is produced by Covishield or the Moderna or the Pfizer vaccines. And these protective antibodies can go through the placenta and protect the baby from infection. Similarly, these antibodies, the IgA ones, can be produced in the breast milk. There has been one case report by Gray and colleagues in the US following pregnant healthcare workers being immunized with the Pfizer and Moderna vaccines, where they have seen increased IgG protective antibody titers in the cord blood of the babies and also in breast milk. So this good antibody transmission does happen both following infection and also following vaccination. On the other hand, there are some so-called bad antibodies or autoantigen-directed antibodies, which can cross over the placenta. And there have been a recent report by Gruber and colleagues, which have suggested that antigens such as anti-LA or anti-Jo1, etc., similar to what you would see when the mother develops lupus, can be seen in COVID as well. And just like you see congenital heart block on AV conduction abnormalities in neonatal lupus, you can find similar issues in babies also. Once these autoantigens cross the mother's placenta and reach the baby, there's a possibility of an inflammatory cytokine formation with inflammatory and prothrombotic activation involving the heart, mucocutaneous tissues, and various tissues, leading to the multisystem inflammatory syndrome in neonates. I want to remind everyone that this is a very speculative pathogenesis issue, and we really don't know a lot about this condition, and there is very scant literature about this particular entity. So I would end with 2 presentations of cases that we had recently here. One was a 41-week gestation baby born to a mother with COVID-19 2 weeks ago, had thick meconium, low Apgars at 1 minute, but picked up very fast, and then developed seizures at 8 hours. And the RT-PCR on the nasopharyngeal swab of this baby was negative, but the IgG SARS-CoV-2 was positive. This baby had pulmonary hypertension, ventricular dysfunction, had high troponin and high BNP a few hours after birth. Compare that with a second child who is a 30-week gestation preterm infant born to a mother with COVID-19 3 weeks ago, who has on day 3 shock, temperature instability, and echo showing decreased myocardial contractility and coronary dilation with aneurysms. And also here, RT-PCR was negative, and the IgG was positive, and IgM was negative. One issue with IgM is that especially preterm infants, even those who have a COVID infection, they may not be able to mount a IgM response. So IgM can be unreliable in diagnosing COVID infection in some of these babies. And finally, this baby also had a high troponin BNP and D dimers. So the first case is definitely not Messian. This is a case of both asphyxia and asphyxia causing increased myocardial injury leading to other problems. Whereas the second case could be Miss-N, and here also the treatment is supportive. But similar to what was described earlier, there has been unproven benefit from IVIG and steroids, and I have seen a couple of cases where IVIG has made a difference, but the need for IVIG should be limited to those infants or neonates who require ICU admission secondary to cardiogenic shock, coronary abnormalities, or more of a Kawasaki disease-like presentation. So to conclude, MIS-C in neonates is rare. Late onset neonatal COVID-19 is a lot more common than MIS-C. Maternal history of COVID-19 and even asymptomatic is present in many of these cases, along with a multi-system inflammatory syndrome with shock, etc., that cannot be explained by any other etiology. Make sure you rule out all kinds of infections, including viral infections, before you jump on steroid therapy in these babies. Treatment is mainly supportive, and again, these cases are rare. And in cases that require ICU support with multisystem involvement that cannot be explained by other causes, with shock or a Kawasaki disease-like presentation, especially with coronary artery aneurysms or dilation, IVIG might be indicated along with steroids and thrombosis prophylaxis. Something unique to neonates is that some neonates, including late preterm and term infants who get IVIG, might develop an ectrodactyl enterocolitis-like syndrome, and that's something to be watched out for. And there are some case reports of IVIG causing significant hypotension in babies with MIS-C. So IVIG is not a benign medication and should be used very carefully. And also, when you use steroids, think of flare-up of an occult infection like the herpes simplex baby that I talked to you about earlier. Again, MIS-N is very different. Pregnant mother who is the one who gets the SARS-CoV infection, and the baby develops the hyperimmune response. But late onset neonatal COVID is a lot more common than MIS-N, and this is a fairly rare entity. Really, thank you for your attention. Dr. Praveen Kumar and Dr. Devrari, thank you for the opportunity, and I will stop sharing my slides.
Thank you, Dr. Satyan. I think this was really wonderful, and especially the immunological concepts and the possible pathogenesis. I think it was beautifully explained and must have answered a lot of questions in the chat box. I would fully agree with Dr. Satyan that MIS-C in newborn is extremely rare. And from India, I could see 2 published reports actually. One came in Lancet, which was a 24-day-old newborn with cardiogenic shock, and the parameters were relatively convincing. Another report came from Assam, which was a 12-day-old newborn with continuing pulmonary hypertension. Other than that, several colleagues have been sharing cases, and I must admit, very few of them are really convincing. Majority of times, possibly people are overdiagnosing, and sometimes, for example, even based on increased D dimers, people are given steroids, and so I think that's pretty being misused. And like in any other disease, I think whole patient has to be looked at, and not only the laboratory, because if people are sending D dimers and CRP, etc., on day 2 of life, day 1 of life, they are bound to be high and misinterpreted. But yes, it can occur in newborns, and definitely we have cases, so we need to be on the lookout. On the other hand, again, the late onset COVID disease in newborns definitely is being seen more commonly in this second wave in India. In the first wave, when we had the NNF COVID registry, which we analyzed and published in Indian Pediatrics, a majority of newborns were asymptomatic, and those who were symptomatic, the symptoms were more related to prematurity itself. But in this wave, definitely we have newborns coming from home in the 2nd week, 3rd week, with definite pneumonia and bacterial sepsis ruled out. And they do behave like COVID pneumonia. But luckily, again, most of them are mild to moderate, being managed with some nasal prong oxygen, and occasional odd baby going on to ventilator and all that. And I think Dr. Satyan rightly reassured us that vaccine is unlikely to create this kind of MIS-C in newborns. So he beautifully explained the pathogenesis. So thank you very much once again, Dr. Satyan. This was really wonderful.
So may I ask Rakesh, Lodha, and Praveen to take questions from the chat box and address to Sushil Kabra. Rakesh, you can address to Venkat and Sushil Kabra, and then Praveen can ask Satyan. And whatever is left behind, I'll ask those questions from the chat box. Over to you, Rakesh.
Right. Thank you, sir. So I think after very interesting talks, we do have a lot of questions. I think while many have been covered in the particularly on pathophysiology and various aspects of treatment, so I'll try and put up some questions. I'll categorize them in terms of the diagnostics and a bit about the therapeutics part, and I'll try and take them and address to both Dr. Kabra as well as Dr. Shankar. And I guess there's some questions about newborns, and maybe I think request Dr. Praveen to collate and ask them. So one of the key questions or challenges that one faces in diagnosis is that you suspect bacterial sepsis or bacterial infection. And you would send out blood cultures, but your cultures are going to be available only 48 hours later. Now, at that time point, what may be indicators where you would strongly suspect MIS-C? Yeah, so maybe Dr. Kabra and then Dr. Shankar.
Yeah, this is really a dilemma. One is that it takes time for getting the culture positive or negative. Another thing is the positivity rate is very low in our country. That's why if the other criteria are fitting and the child is very sick, we decide to start the treatment, and empirically, that's why in our algorithm we have suggested that start empirically antibiotic also to cover for the common organism in that setting. So that is our response, because overnight we cannot change the results of culture and availability of culture report. Though there are certain other things which may give culture report within few hours, but still most of our clinical setting, they do not have this type of setting.
Yeah, Dr. Shankar, what would your response be?
I think I agree with Dr. Kabra. I think there are many patients, even in our setup, that where the bacterial infections may not be as high prevalence, we would not have the confidence to not start antibiotics. So if many times if the inflammatory markers and the age and the rest of the picture, it's very unclear whether it's a septic shock versus a cardiogenic shock, or it's a myocardial dysfunction secondary to bacterial sepsis. We would start broad spectrum antimicrobials. I think in terms of starting either steroids or IVIG, honestly, in case the clinical picture is much more suggestive of a sepsis, then there is some time and one could wait 24 hours or more without causing significant decrement in the outcomes for MIS-C. So I think bottom line is definitely a 24-hour delay in antibiotics can be life-threatening, but we are not so sure about IVIG or steroids and being that time critical if you are in an ICU setup.
Right. So I think taking from that, I think the next I would issue is a challenge between, differentiating between what is a severe COVID-19 versus MIS-C. So Dr. Shankar, what would your suggestions be? So there could be overlaps and there could be scenarios where there could be severe respiratory disease, there may be cardiac dysfunction, your markers may be elevated. So how would you, what advice would you have?
No, that's a great question. There is a very small subset of patients where, and I think as Dr. Kabra described in the WHO's and the CDC series, one of the categories, and these are typically older patients. These are typically patients who have significant respiratory symptoms. The classic MIS-C that we earlier learned did not have as much respiratory manifestations. So I think if the symptoms are more suggestive of respiratory illness secondary to COVID-19, then that's where we start treatment. And so I would say steroids are often used in a certain phase of COVID-19. So I think one could rationalize the use in a very sick patient. We do not jump to IVIG early on in some of these patients. We will manage the respiratory support, shock state, and then decide if really we think this is more looks like a hyperinflammation associated with COVID-19. And that coexistence of COVID-19, active COVID-19 with hyperinflammation is a described entity, and I think it can be treated with one of the immunomodulators. We do not use Toci or any other of the drugs that I saw in one of the series in India.
Yeah, so I guess I think the attempts are there to kind of differentiate between severe COVID and MIS-C, and I think there was a publication recently in the JAMA, which again, I think what we get is just broad differences. There's no well-defined, let's say, score or something which would help you, differentiate. So whatever features have been highlighted, we could say certain features are more often in MIS-C as compared to the severe COVID. But I think we'll probably need some more data and more better characterization of the disease, which may help us to differentiate, because the management to some extent would be different. There is also this issue about, the utility of echocardiography. So, Dr. Kabra, this is, let's say, in many of our setups, we wouldn't have echocardiography available. So in that kind of a setup, one is we use shock as a marker for cardiogenic or cardiac dysfunction. But what would your advice be? How do we go about diagnosing?
Yeah, shock can be taken because this is a myocardial dysfunction, and it can be taken as a surrogate marker for a myocardial dysfunction. If echocardiography is available, we may be more certain, but if that is not available, it's fine. We need to treat on the clinical examination, clinical findings.
So going to the markers per se, so procalcitonin is listed as a marker along with CRP and ESR, but we also know that procalcitonin is a marker for bacterial infections as well. So one, how would you would you take procalcitonin elevation alone as a marker for raised inflammation or marker of inflammation, or would one consider that if, let's say, CRP is elevated but procalcitonin is not detectable or negative, does that go more in favor of the inflammatory syndrome rather than a bacterial infection, sepsis? So maybe Dr. Shankar.
Yeah, honestly, I do not know what's the right answer because it's true that majority of the patient of MIS-C have significantly elevated C reactive protein. So, but procalcitonin could be variable. But your point or the question that has been asked is procalcitonin is a non-specific, and so is C reactive protein, and so is every other acute phase reactant. And they may reflect an infection or inflammation secondary to hyperimmune response. So I think one has to, that's why I think if one thing I could say, and I saw some chat questions about if the D dimers are high, can we use this or that? I think the people should not just take just one marker and one lab to decide the treatment. The treatment has to be decided based on the entire picture, the clinical picture of the patient. Shock is not necessarily a reason to give pulse dose steroids. You can shock has to be managed with like we'll manage any other shock, and can be started with first line therapy. At least we do not, just because the patient is requiring 2 inotropes does not mean you give a higher dose of steroids. You can still start with the same initial line of management. If there is refractory response, meaning the patient is still showing signs of inflammation, fever, and non-response in terms of cardiogenic markers or echo, then we can increase the steroid levels.
Praveen, can you take questions for Satyan?
Yeah, so I think the questions that Dr. Satyan are quite common. And one of the questions which is coming up is, obviously everybody wants to predict. So is there a way to predict which newborn is going to develop MIS-C base, can we correlate it with, let's say, maternal symptomatology or maternal viral load or maternal antibody titers? Is there any way one can predict?
That I know of, quite a few cases that we have seen turn out to be mothers who have been asymptomatic. One of the things that most US hospitals have instituted just to make sure the obstetricians and anesthesiologists are not exposed is to routinely screen all mothers when they come into the hospital for admission for delivery, actually a day before their admission. And quite a few of them turn positive, and that's where we see this. So symptomatology in the mother has not been a predictive issue here. As many of us know, having COVID during pregnancy has not been good. The mortality, ICU admission, need for ECMO, intubation, all are much higher in mothers during COVID. So there are lots of questions about vaccination as well. And I think it's, at least in the US, with the 2 mRNA vaccines, there is more safety data now. There is a publication with over 1,800 mothers where the neonatal mortality is 0 and things look very good. So both the ACOG and the AAP have strongly advocated for the use of vaccines. And as I mentioned, vaccines cause good antibodies, and those are good for the baby compared to the bad ones that cause MIS-N. So I think promotion of vaccination during pregnancy and lactation is probably very important as well. But to answer your question, I do not know any predictors that will help you decide what makes the baby develop any of these conditions.
Yeah. I think the challenge with the vaccination now is that in India, obviously, we have only Covishield and Covaxin at the moment. And Covishield is the dominant vaccine being used. The current GOI website mentions not to be used in pregnant and lactating mothers, but I guess, I hope this will change soon, although I don't think we have any data to suggest that. Maybe Dr. Rarity will offer more information on this later on. One question is about, I think it's applicable to both newborns and children. Somebody is asking, what are the cutoff for these inflammatory markers, especially in the newborn? You know, in the first week, for example, what is the cutoff for D-dimer, CRP, and ProCal, and maybe LDH? Because people are interpreting that and trying to treat those markers per se. So is there any information, Dr. Satyan, that how do we decide it's?
No, I'm not aware of any information that clearly differentiates the two. And sepsis and asphyxia fairly unique to newborns, as we all know, is something that's very, very difficult to differentiate between something like MIS-N or even COVID. So there are no clear-cut guidelines. And as Dr. Venkat was mentioning earlier, the CRP tends to be pretty high in some of these conditions. But late onset COVID versus MIS-N versus other infections, they are very difficult to differentiate. And you need to have a high index of suspicion, but also make sure you rule out common things. Common things are more common, and those things should be ruled out before jumping onto therapy for MIS-N.
Yeah, I would agree. I mean, especially in the first week, like at least for CRP and ProCal, we have a lot of data to suggest you can have phenomenally high levels even in the normal routine perinatal conditions, and they are not good even for bacterial sepsis.
And the reason I started off with a case of herpes simplex that was a case where I personally was burned, assuming it to be MIS-N because of the prevalence of infection. And when the PCR turned out, using steroids on that case was a bad mistake. And I just want to make sure nobody repeats that and thinks of infections before treating these babies with high-dose steroids.
Yeah. There's a question about although it's not MIS-C question, but about testing the newborn who is born to a mother who is COVID positive. Should we test, and when should we test? And if we don't test, then does this newborn pose a risk to the, let's say, grandparents at home?
Initially, when more infections were appearing in China and the infection was new to both India and US, all kinds of various restrictions were placed, including routine testing on babies at 24 to 48 hours, which was the AAP recommendation. But increasingly, it's being recognized that a baby testing vertical transmission is almost unknown. There are anecdotal reports of vertical transmission. So for practical purposes, there is no vertical transmission from mother to baby. So any transmission that occurs during the process of birth or postnatally, and most likely from the mother or somebody else who is infected. So unless the baby is symptomatic, right now we personally are not testing newborn. And so if the mother is using usual precautions and everyone at home is using usual precautions, I think there is no indication for routine testing. But if there is somebody who is elderly at high risk who is involved and testing is warranted, maybe it can be considered. But for the most part, we are limiting it to symptomatic newborn, and asymptomatic, we are just letting them be to continue routine care. Things like breast milk and maternal bonding are a lot more important than isolation and things like that during this time. And the fact that no virus has been detected in breast milk, but lots of antibodies are found in breast milk also leaves credence to the fact that breastfeeding and things like kangaroo care are very important, even for mothers who have COVID.
Yeah, no, I agree with you that roaming in and breastfeeding obviously have to be recommended, and the testing should not hinder this process, and that is definitely recommended. When the NNF-IAP guideline came up last year, nearly a year ago, at that time we said the newborns should be tested, and the reason we postulated was since children have been shown to be important kind of transmitters of infection to the families, that maybe newborns could also. So we obviously did not have data to suggest that. But certainly we are not going to isolate the baby just because baby is positive. And in the current scenario, when you test anyone and I think every other person is positive, it may not be really so important. There is a question about, I think maybe it's applicable to newborn children. Somebody is asking that in case somebody has COVID and the fever is persisting beyond 5 days, should they start investigating for MIS-C, or if the fever is simply because of the ongoing COVID infection? Maybe anybody can answer. Yeah, Shankar, maybe you can.
I think the classic MIS-C is typically weeks after the COVID infection has happened. Whether in the particular child there was an active infection, symptomatic infection, or an asymptomatic infection. I think it's very rare for us to see MIS-C as like to have a diagnosis of MIS-C on top of COVID. Active COVID is kind of a rarity, and I would say that more likely this is either a persistent COVID infection and or inflammation associated with that, rather than. I know we are enamored by new labels and new names, but I don't think this would be classically a MIS-C.
As part of the COVID infection, we obviously are seeing a lot of people continuing to have fever beyond 5-7 days also. So there's a question of Satyan, a difficult one, I know, because the diagnosis of MIS-C newborn as such is so rare. So people are asking whether they should give dexamethasone versus methylprednisolone versus IVIG if they have to use something.
Fortunately, there is no clear-cut data. We do have some internal guidelines that we use within our own institution, which have absolutely no basis from evidence. We are limiting the use of IVIG to patients that are either in shock or have significant myocardial involvement or have coronary aneurysms or significant coronary dilation. So in the absence of those entities, we are not using IVIG, and especially more than one system involvement, cardiac plus one other system involvement. We're limiting IVIG to these entities. The choice of steroids, even there is not much known. I do not know a lot of use of dexamethasone. Most often they're using either methylprednisolone or hydrocortisone in neonates. So that has been the extent of what we know so far. So this is, first of all, we are not really sure if MIS-N exists. And so speculating on treatment is, I think it's premature at this time. Most often it's symptomatic treatment. There are a couple of questions on COVID-19 pneumonia in babies, and the treatment even there has been predominantly supportive. I have seen some cases where surfactant has been beneficial, especially if the baby is preterm and also has COVID-19 like pneumonia. But other than that, we do not know much specific therapy. So unfortunately, there is no clear-cut choice for steroids for treatment of MIS-N at this time.
Yeah. Okay, the couple of questions related to COVID management. So somebody's asking, should we make the newborn wear mask of any form if baby is positive? So I think this is straightforward. No mask for less than 2 years are recommended.
The risk of asphyxia from the mask itself is so high that we don't want that to happen.
So I think WHO recommends no mask below 5 years of age.
5 years.
World Health Organization. Rakesh, am I correct?
Yes, sir. Below 5 years and even beyond 5 years, you need to have it. So it's going to be, it has to be specified and there has to be supervision and the risks have to be considered strongly. And it's only beyond 11, 12 years of age when we expect that the child would be able to handle the mask well. That's when it would be. I think better thing is for the adults in the family and others to actually use the mask properly.
So I think there are 2-3 questions which are for Sushil and Venkat. How common is kidney injury in patient with MIS? Sushil or Venkat?
Yeah, I think the original few case series had around 10 to 18% cases with some renal injury. We haven't seen that as a major manifestation other than patients who have required going on ECMO. So the kidney injury is usually secondary to a prolonged shock state. And sometimes it is secondary to nephrotoxic agents that we use. But it's not a very prominent feature of end organ dysfunction other than a secondary to shock.
Sushil, there is one question for you. How to correlate lab tests in tier 1 and 2 with severity of disease? This is by Dr. Ahmed.
Yeah, this tier 1 and tier 2 is to identify, one is whether there is an inflammatory process, as I have shown you. Second thing is to identify the organ dysfunction. These tests are not related to the severity of the disease, but it is to identify the organ dysfunction, whether there is a myocardial dysfunction, whether there is a renal dysfunction, whether there is a liver dysfunction, so that supportive care can be given. But I am not aware whether any of these tests can correlate with the severity of disease and then you decide about the treatment. Treatment is decided on the basis of what is the organ dysfunction and what is the clinical condition of the child.
Sushil, another question
if I could re-emphasize, I think I see a lot of questions which basically which basically say that a lot of questions about isolated D-dimers or this or that. D-dimers are very notoriously all over the place. And a patient who's doing very well, we can suddenly have an abnormal value which is going in the opposite direction of where the patient's overall condition is. So I think, as Dr. Kabra rightly said, you have to take the whole picture into consideration: fever, shock, end organ function, and then use the biomarkers as one of your adjunct tools to help you in decisions rather than just treating based on labs.
Sushil, another question for you from Dr. Anand. Do we give single methylprednisone for 3 days? And after giving this, can we shift over to oral steroids?
Yes, depending on the general condition of the patient. One is that you are giving us methylprednisolone in the usual doses and subsequently you will taper it over next 2 weeks. But if it is refractory, in that case, you will give for 3 to 5 days higher doses of methylprednisolone and then you taper it.
So one question is for Praveen and Sushil, you. Is there any plan by Indian Academy of Pediatrics or NNF to make a registry of MIS in children and newborn babies? Any plans? Or you want to make appeal?
Yeah, so as far as the newborns are concerned, so NNF had started a COVID registry last year, and we had nearly 1,600 COVID positive women registered in that, and the data was analyzed and published. And we are adding a page on a screen on the MIS in newborns, where we want to capture wherever people are suspecting, and then ultimately, obviously, try to figure out whether they were true MIS-C newborn or not. And I would request and suggest all other people who have not yet joined the registry to please go on the NNF website, There's a hyperlink, or they could directly go to the site innc.org and register themselves and start sharing the data for mutual learning. Dr. Kabra?
Sushil?
Sir, I am not aware whether Indian Academy of Pediatrics is doing it, but I definitely support that we should have a registry so that we can have a uniform data collection and analysis to decide about policy that how to manage these patients.
So I think there's...
Sir, if I could add, I think there's a registry that's been done by the ICMR, multiple centers across the country, which does include all patients who are in a COVID kind of hospital or a center. And they are collecting data on MIS-C as well. But as of now, as I mentioned initially, the overall numbers aren't too great. I think we would need registry. A lot of MIS-C is going to be handled in pediatric intensive care units and so on. And I guess from what we hear in the groups, people have managed quite a few cases over last few weeks or months. So certainly, I think for learning, it would be good if we could have a registry in place.
So one more question for Sushil. Sushil, what are the indications for giving aspirin in a patient on follow-up?
As I had shown you this thing, that indication for aspirin is one is if there is a dilatation of the coronary with a Z score of less than 5. And another thing is thrombocytosis. You give it for 2 to 6 weeks, similar to that of Kawasaki disease. And then once that is reversed, you can stop it.
So are these guidelines different as compared to what Venkat was saying, or are these same?
They are same, sir. They are same.
Okay, so I think we are just nearing the end of this webinar. Before we end, I would just like to share with you 2 small stories. Why did we choose to have this seminar on multi-system inflammatory syndrome in children? And the reason for that is that this is what I got on WhatsApp. This is 3 weeks ago, that there is a child who was 29 months of age with upper respiratory tract infection. Child had fever, then rash over legs and even over the body. And then they got a rat antigen done, which was positive. The child moved from Bombay to Jammu, and then they got some tests done, like D-dimer test, which was very high. And to me, it was not any multi-system inflammatory syndrome or any type of COVID. It was just a viral infection which was happening. And maybe due to some drug, there was skin rash. So we gave only cetirizine to the child, and we did not treat the report of D-dimer, which the doctors in the other city was worried. And they consulted me, and I got worried that people are making overdiagnosis of MIS by doing investigation and looking at skin rash and the child who was COVID positive, and there was no, it was not occurring after 2-3 weeks. They did not do any antibodies also, and it was like diagnosis which was not conforming to what WHO or CDC definition was. And the second, and then once I told the family to send me, after giving antihistaminic, a picture of the child, they sent me a picture after 3 days. The child was very active, playful, interacting, and the rash also disappeared in the child. And the second was another case scenario, which was being managed by one of the neonatologists in the city, away from New Delhi, that he had a child who was 6 months old, who presented with cough and cold and fever. His RT-PCR test was awaited. While the child presented, these were the investigations which were done. He did ferritin, which was on a higher side. D-dimer was more than 7,000. LDH was 625. Neutrophil to lymphocyte ratio was 1.2. Blood gases were like this. Child was started on IV antibiotics. Echocardiography was done. Ejection fraction was more than 50%. Coronary arteries were normal. Methylprednisone was given. Injection enoxaparin was given in view of raised D-dimers. And I debated. I thought it was a case of a severe COVID pneumonia in the child. And then the child was ventilated, extubated. He was given methylprednisone, treated like this, extubated. Now the child is well. Now, I don't know, Sushil, what do you think this child has? Severe COVID pneumonia or MIS? See.
Sir, it suggests more of a severe COVID pneumonia rather than MISC. We have to see the case definition. Along with that, the course, and we interpret the results in the context of the clinical condition of the patient.
So I think similarly, Satyan gave a lot of examples that while you are having COVID infection, where you have pre-test probability of having COVID positive test, or even the antibody IgG positive in the child, in a newborn baby may be there. Sometimes we forget about the primary disease and we think it is MIS in newborn and then start treating that with methylprednisone. So I think we have to fulfill the definition. We have to be careful while we are making a diagnosis of this and try to do all investigation in the child before you label this baby as MIS in newborn or MIS in children. So in the last, I would ask each one of the moderator and each one of the speaker to tell us one carry home messages for all the participants. So let me start with Venkat. And please don't repeat the message. Venkat.
So I would say that with too much of fascination for a new label and new disease, which we fully do not understand, we should resist the temptation of jumping and forgetting that a bright thing which rises on the eastern horizon every morning is usually the sun, not a UFO. So I think that's even in the current situation where everything we are worried about COVID, I think the most important thing is to remember that much more common diseases exist and just not treat a single value like your last case of just D dimers being high, whereas the CRP was only 10. So I think that's, so the take home message is use your common sense and not be enamored by labels and new diagnoses.
Sushil.
Sir, I would say keep a high index of suspicion for diagnosis of MISC or complications of COVID, but keep a low index for starting treatment in form of remdesivir, IV methylprednisolone, or IV IgG. Just see that yes, the child may have a COVID problem, but whether he really benefit from any of these or whether I am causing harm to the patient. The first thing should be that I should not be causing harm to the patient.
Praveen.
I think before I give the message, I can't resist myself from sharing the story of D dimer. I reviewed around 10-12 cases of so-called missing newborns by some people had collected. And of them, 6 were isolated increased D dimer and treated with steroids, etc. And one of my own family members who had severe COVID pneumonia, recovering, D dimer kept on increasing. So finally we stopped doing it. So let's ignore it and not do it. So anyway, I think definitely late onset COVID disease in newborns is increasing, and we are seeing more and more cases in this wave, certainly. But I think MIS-C is obviously very, very rare, overdiagnosed, and I think we should look at patient as a wholesome and not start doing unnecessary lab work and start treating those laboratory parameters.
Thank you, Praveen. Rakesh?
Yeah, so I think we just need to, it's still an emerging condition, and there may be some new manifestations or atypical manifestations. So I think we just need to be on the watch out, but I think we should be resisting, the temptation, particularly when we get around IVIG and so many other medications, or really getting after investigation, which routinely may not be available in many parts of the country. I remember, like, when you have to do the cytokines like IL-6, there's a very strict protocol around collecting, transport, and analysis of these. And these days we would just have it, you order it, we don't know how it's been collected. how much time it's taking before the samples are analyzed and so on. So there's a whole lot of variability that would be creeping in. So I would really agree with the esteemed panel that stick to your basics of clinical medicine while you look at the other information that you collect. But I think those shouldn't really override your clinical judgments or more hard facts. And I would just urge everybody to stay safe, particularly during this wave. So that's what I would have to say. Thank you.
Satyan.
I'd like to re-emphasize that given the prevalence of COVID among pregnant mothers now, do not rely on IgG positivity because that will be almost seen in 30 to 40% of newborns moving forward. So do not rely on single tests. Examine the baby. Think of the baby as a whole baby and not as an individual organ system. And again, everyone, please stay safe. These are really trying times. And Dr. Devarari, thank you very much for organizing this. This was very helpful to me as well, listening about everyone's experience. This is a time when India is teaching everybody else. You have such high prevalence and such good sciences coming from India, and we are eager to learn from your experience, and so that we can appropriately treat and unnecessarily not use excessive resources in these children. Thank you.
So on behalf of Department of Pediatrics and on behalf of All India Institute of Medical Sciences, I thank each one of you. I think it has been a great learning for me listening to you and then revising how children also have to be treated for COVID. Though at this point of time, I am treating adult patients who have got like moderate disease of COVID at home. So it's great learning for me. And I would say we should not over-treat and over-investigate. Do a good clinical examination, keep the primary diagnosis in mind and treat that. COVID may be RT-PCR may be positive in the child. It may be due to, because as Satyan said, we have high pretest probability at this point of time. So we have to treat the primary disease, keep your focus there. And also remember, we have to be safe. We have to make sure we take all universal precautions, just we take for HIV. But the additional thing this time is we have to wear N95 mask or a double mask while we are treating our patients in the outpatient and in the hospital. So this is going to become a part and parcel for healthcare professionals that we will have to have a mask or a double mask while we are treating our patient in the hospital, in addition to following all universal precautions which we take care, like hand hygiene and social distancing, physical distancing, which we have to maintain for taking care that we are safe while we are treating our patient. Thank you once again, Satyan, Venkat, Rakesh, Sushil, Praveen, and Puneet and Pratima, who were handling the back end for doing this webinar. Thank you so much. Thank you.
Thank you. Right.
All the best.
Bye-bye.
Right. Thank you.
Bye-bye.